Raman's 26th virtual shadowing session. Today we'll have Dr. Malhotra. He's an associate professor of neurology at the WashU St. Louis School of Medicine and the president of the American Academy of Sleep Medicine. This meeting will be recorded, but we encourage you to have your cameras on as it increases interactivity with our speaker. We hope you enjoyed today's session. Dr. Malhotra, whenever you're ready, you can get started.
Great. Thank you again for the invitation, and welcome everyone joining us this evening. Wanted to start off with obviously just a brief overview of my journey, and then I think we can dive maybe a little bit deeper into neurology and sleep medicine, which are the two things that are my specialties that I spend most of my time doing professionally. So I grew up in St. Louis, Missouri. That's obviously where I'm at right now. So I eventually came back home, but that's where I grew up in childhood and high school. And then I entered a 6-year medical program at University of Missouri, Kansas City, which is about 240 miles or so from where I grew up, so not too far away. And then when I completed medical school, I did an adult neurology residency, which was 4 years long, and then did a sleep medicine fellowship, which is an additional year, both at University of Michigan and Ann Arbor, Michigan. And then after I completed my training, I stayed on at University of Michigan. My wife was also a physician and she was finishing her training. And so I stayed on and then eventually moved back to St. Louis, where I have a lot of my family. So I initially joined St. Louis University School of Medicine, where I did neurology and sleep medicine, which is basically what I currently do at Washington University in St. Louis, which is essentially right next to St. Louis University. And I've been at my current position for the last little over 3 years. So I moved to Washington University in 2018. And just I thought I'd start off with kind of what I do day to day. And then, like I said, I'm going to kind of go through a little bit more details of my journey and then talk a little bit more about neurology and sleep, just for those of you who maybe don't know as much about the specialty. And then obviously, I actually brought a couple very quick cases, which I think I'll be able to get through. And then we'll hopefully leave enough time for questions. If not, I'll throw an audible if I've taken too long. We'll just get to the questions. But so, what do I usually do every day? Well, most of my time is clinical. So my position is mainly seeing patients. There are definitely my colleagues at my university that do a lot of research. We all do quite a bit of teaching. I do quite a bit of teaching as well. Most of my days I'm with either residents, medical students, or a sleep medicine fellow. Almost every half day of the week. So there are times where I work on my own, but almost always I'm working with a fellow. I had a fellow with me today, and so they would see patients usually on their own, and then they would kind of report back to me and discuss the case, and we do some teaching, and then I'll go see the patient with them. And we do that in person and virtually during this COVID world. So my clinics are about a 50-50 mix of telemedicine, meaning actually via Zoom or in person. Obviously, before COVID, it was all in person, and I'd never seen a patient over telemedicine until COVID. So that's, as I'm sure you've probably figured out, one of the changes during COVID that I think was good, one of the few things. And as far as I'm seeing patients with different sleep disorders mainly, so insomnia, sleep apnea. They're really sleepy and tired during the day, and we need to figure out why. Maybe some weird movements during sleep, or sleepwalking, or acting out their dreams. And then I read sleep studies during certain my half days as well, where people are coming in overnight. We'll talk a little bit more about that at the end of my talk. And then I do cover some inpatient time. And what I mean by that is where people have acute neurological injuries, stroke, problems with thinking, seizures, masses or tumors in their nervous systems or brains, where they have to unfortunately get into the hospital or to the emergency department. And then with my other colleagues in my department, we take time sharing that coverage of the inpatient service, which with, again, usually medical students, residents, and fellows. We do have set didactics as well, where I'll spend an hour maybe per week, where I'm supposed to be giving, noon conference or lectures to one of the trainees in our medical school. And then, as mentioned before, I'm currently president of the American Academy of Sleep Medicine, which is our specialty society. And that takes up quite a bit of my time for this year. I took over in June, and I'll be finished next June. And so a lot of my times are different meetings with things that the academy is doing. With the academy, you typically are dealing with are kind of global patient care issues, maybe dealing with COVID, maybe dealing with problems with access for patients. We also deal with advocacy, where we're talking to legislators in Washington, D.C. about issues regarding sleep disorders or getting research for sleep disorders. Those are just some of the things that we deal with, along with different conferences and educational items for our members. So let's talk first about neurology, and why did I choose neurology? I don't have really any other family members, meaning my parents or my uncles and aunts, that were in medicine, but my older brother was in medicine. He actually is an ophthalmologist, and so I really didn't have much a mentor or anyone in neurology as I was going through medical school. But what really had me choose neurology is when I rotated through neurology, I really did fall in love with it. I had it very early on, so I had an open mind about looking at other specialties. And when I got done with the rotation, I wasn't like, oh, that's for sure what I'm going to do. I just kind of assumed all the rotations were that exciting. And then I later found out that I probably enjoyed neurology more than most people did. And what I really enjoyed was the brain and the nervous system. I just found it, I definitely realized I wanted to learn a whole bunch about kind of one organ system. So I wasn't as enthusiastic about kind of knowing a little bit about everything, which, is what a lot of other primary care specialties, for example, would do. And then I thought, of all organs, the one that's the most complicated and interesting and fascinating, and for better or for worse, that we know the least about, is really the brain. And we'll talk a little bit more about some of those things that make it challenging and interesting. I put a bow tie here. The other thing that neurologists are known for, which I should have wore one, I guess, is that they tend to be stereotypically have like a bow tie, and they always have their bag of tools with a reflex hammer, because when you think of neurology, you'll see the exam really plays a really critical part of choosing that field. So, with neurology, 1 in 6 people are impacted by neurological disease. So you'd be very, very surprised as we talk about all the different, unfortunately, common diseases that patients suffer from. And one of the other things that I heard when I was choosing neurology, which mind you was about 20 years ago, what they would say is that, wow, neurology is really interesting and exciting to learn about how the brain works. But once you figure out what they have, you can't really treat it. And they would give examples of things like people who've had strokes, who, no, they still can't walk, or ALS, or Lou Gehrig's disease, or motor neuron disease, where that's a horrible disease where people get weak and die rather quickly. And those are horrible patients to have to treat, in the sense that not they're horrible, but the diseases are horrible, and it can be depressing, and you could argue is not something that a lot of people will look forward to if they're wanting to help people. But however, the other way of looking at it is there's been a huge explosion in the amount of treatment options we have for neurology. And most of the people saying that had never looked into things more recently, especially even over the last 20 years that I've been practicing. I'll give you an example. For a condition like multiple sclerosis, when I was training, there were only 3 medicines available, and now I believe there's probably closer to 20. And so we have all sorts of different gene and enzyme replacement therapies, implantable stimulators that can help with seizures and motor function and sleep apnea. There's a lot of immunomodulators where you can kind of infuse people with medicines that will help with their autoimmune conditions, and of course a whole bunch of different medicines. And so kind of the thought before that with neurology you can't really treat anything is kind of more old news and not true. And there's some really impressive diagnostics now too. One of the most difficult things to do in neurology was to get to the brain, right? We don't want to mess with the brain with a biopsy or going into the skull. And so we really have to look from the outside. But here's a picture on the upper left corner of an MRA, or it's looking at the vessels. You can see from the arch of the aorta, this is just using a magnet. So it's an image. So we don't have to harm the patient. They just kind of lay in a tunnel and get an MRI, but it's called an MRA. And you can see, look how clear you can see these vessels. Pretty impressive without having to give them any kind of, it's not an angiogram or anything. It's literally just taking a picture that you can kind of rotate and magnify. Here's on this right side is an EEG or electroencephalogram, which is looking at the electrical signals of the brain. But this is a high density EEG, and you can see all the different electrodes that looks funny, but it's pretty painless for the patient. And you can see it not only gives us all sorts of weird spectral analysis and signals that we can really see what's going on electrically with the brain. And to the lower left corner here is a PET scan looking at metabolism of the brain. And so I only mention these things to show that we're really getting a lot better understanding of the brain without having to be really invasive or inconvenient to the patient, in the sense that we're not injecting things or cutting into them to get this information, which we probably had to do back in the day. As far as different subspecialties of neurology, I kind of listed some here. Movement disorders includes things like Parkinson's disease. So if you're a neurologist, you can actually specialize in seeing mainly patients with different tremors and movement disorders. You could obviously be a general neurologist where you see all of these, but there are stroke specialists, epilepsy or seizure specialists. Obviously, I'm a sleep medicine specialist, which we'll talk about a little bit more. Multiple sclerosis. There's a branch called sports neurology, which is dealing with athletes with athletic problems. And the big topic there is concussions, which you can imagine is a huge issue. Neuro-ophthalmology, where you have an eye issue that also involves kind of the nerves going to the eye. Neuromuscular is things like neuropathies and myotonic dystrophy and different muscle nerve diseases. Neuro-oncology is dealing with cancers of the brain and nervous system. Dementia or memory fellowships can be done where you're dealing with patients with Alzheimer's disease and other memory issues. Ataxia is where people have usually neurodegenerative conditions that cause problems with balance, which is also what neuro-otology is, kind of the inner ear issues that cause balance or vertigo. There's neurocritical care where you're dealing with people in the intensive care unit with neurological injuries, and then rehabilitation after someone comes out of the hospital, getting them strong. And so I'm kind of mentioning just some of the breadth of things that if you're a neurologist, you could see all these things. You could also specialize in one of these and spend most of your time just doing that. And what I'll say about neurology is you could deal with something as that's kind of hospital based, like stroke, where you would need to be on call, and you could actually be called to see someone in the emergency department, and may even administer things like clot busting agents, or some neurologists will even do angiograms and take clots out of the vessels to prevent a stroke, where you need to be close to the hospital. Or you could do something like sleep medicine, where I'm mainly outpatient, where I'm dealing with people in clinic and there's not really any emergencies. I'm not really seeing people in the emergency department. So you have, and then there's specialties, for instance, like multiple sclerosis, where you're following patients long-term and probably for the entire life of the patient, where you can establish a long-term relationship if you like chronic diseases. So it really does run the gamut. The other thing that kind of comes to mind if you think of neurology is this kind of localization is what we call it. And what we mean by that is we use a very detailed history and physical exam to try to figure out where in the nervous system or brain the problem is occurring. And so we look at things like strength and reflexes and eye movements and all sorts of different things on the exam, trying to decide what part of the brain is maybe being affected. And then that can help us decide maybe what is the etiology. And what I really like about that is it is like a puzzle. I showed here on the right side, there's even board games that use these different cases to kind of localize where in the brain something's happening by showing you different symptoms and signs. And so it really is like a puzzle. A lot of medical students that I know that choose neurology like going into neurology because they feel it's like a puzzle where you're given history, and then you do a really detailed exam, and then you come up where you think the lesion's at, and then come up with maybe ideas of what could be going wrong. And I mentioned that because this is definitely not a field where you're seeing patients very quickly. You have to be someone who's probably more detail oriented, who likes for example, it's not uncommon for a neurologist to spend 45 minutes to an hour with each patient, which obviously would not happen in every field. And part of that is talking to the patient and talking to them. It's actually our exam and history itself are so detailed that it can take that long to gather all the information. And then the other thing I'll mention with neurology is that you have to be comfortable with the unknown. The brain is not all straightforward. And so it is not uncommon to be in the hospital and someone's having something go wrong, and you go through your evaluation and your testing and still not exactly sure what's going on. You have to be comfortable with that and not let that drive you nuts and not be able to sleep that night, because this will not be the field for someone who needs to know exactly what's going on. And again, not suggesting that other organ systems are easy to deal with, but you can imagine a kidney or the lungs are more straightforward, and we learn a lot more about them than something like the brain that really is still a mystery to science. So kind of transitioning to sleep, which is, again, actually what I spend most of my time doing is sleep medicine. And so I wanted to kind of touch upon what exactly does someone who is a sleep physician do. And so, a third of our lives is spent asleep. In the past, we've always felt that sleep was a passive state. If you look at literature from kind of the beginning parts of the 20th century, they kind of assumed everything was kind of off at nighttime, and then, why measure anything? And once they started to measure what was going on during sleep, they realized it was actually an active process. And here's a couple interesting quotes from two kind of legends of sleep research. The first is, if sleep does not serve an absolutely vital function, then it's the biggest mistake the evolutionary process ever made. Again, suggesting we're spending a third of our lives doing this, clearly there must be a function. And then the second is, more has been learned about sleep in the past 60 years than the preceding 6,000. So really everything we know about sleep is relatively recent when you look at things in a spectrum. I put up a book title here, The Sleep Revolution, just to show you that the other thing exciting about sleep is that a lot of our patients and a lot of the world is really excited about it. So it's not just something that in the medical field we're learning more about, whether it's someone like Ariana Huffington or Russell Wilson, who's a quarterback for the Seahawks, or other athletes, politicians, authors. They've noticed that getting good sleep is critical for their success, to be healthy and to perform optimally. And so sleep medicine as a specialty, it's a one-year fellowship that you do after a residency. And what's very interesting about sleep is you can do it after a whole bunch of different specialties. So for example, I did neurology, but you could do psychiatry, you could do pediatrics, you could do family medicine, you could do ENT or otolaryngology, anesthesia, or internal medicine. So we have people entering the field and they do a one-year fellowship, which are coming after a different residency, right? You can imagine someone doing family medicine is different than maybe someone doing psychiatry or ENT. And so that's one of the fun things about sleep medicine, is that it's multidisciplinary. I did put a website here. It's called choosesleep.org. And it's actually a really good website for anyone interested in learning more about a career in sleep. It has a lot better information than what I'm going to go through here shortly, with some cool videos and so forth. So if you want to check that out, feel free. And so, why did I choose sleep? Well, what I noticed as I did my neurology training, because I did not know I was going to go into sleep medicine until the end of my neurology residency. We did see sleep patients during our residency, and we could do kind of an elective in that. But what I noticed is that it really impacted almost any patient, whether I was seeing a patient with memory problems or a concussion or Parkinson's disease or stroke. Sleep was critical. If they weren't getting good sleep, they weren't going to be able to handle their primary neurological problem. And what I put up here is a statement that the American Academy of Sleep Medicine just published, which is sleep is essential for health. And one of the pushes in science now is that sleep is as important as nutrition and exercise in regards to optimal health. And so, really it comes down to why do we sleep? Right? That's the question. And I don't think we have a single easy answer. We do know that it's involved very heavily in memory and thinking, right? If someone isn't sleeping well, it's not uncommon for them to have memory problems or not feel like their thinking is clearly, maybe not do as well in their classes. It can be connected to longevity, or just basically how long you live in life. And then we tend to think of sleep as restoring function, right? If you go to sleep at night, your heart's going to rest, your immune system is going to be able to kind of ramp up and get ready for the next day. Your endocrine and hormones all kind of go to different levels and kind of tone down for the night. But we also know there's a nice connection between pain and sleep, and meaning that if you don't sleep well, you'll actually notice more pain the next day. Definitely mood and behavior. Anyone who's had friends or younger siblings or babies in the house, you'll know that if the baby or child's not sleeping, they'll have definitely be more irritable, and that even happens in adults as well. And then even things like strength and coordination. I talked about some of the people who are really into making sure they sleep well. Olympic athletes. I know we just got done with the Olympics in Japan. Many of those athletes really focus in on their sleep to make sure that they are getting optimal sleep for their strength and coordination. As I think you could imagine with some of those athletes. I remember watching one of the swimming competitions, and there was like a difference of like 0.02 seconds between gold and silver, which you can imagine that kind of margin of error. They're probably looking for every little edge they could get. Unfortunately, most people in the United States do not get enough sleep. This is a poll called the Sleep in America poll that the CDC also tracks, and a third of Americans report they do not get the amount of sleep they need. 20% report that they either never or rarely get a good night's sleep. So that's 1 in 5. And you can see the Institute of Medicine in the early 2000s estimated that 50 to 70 million Americans chronically suffer from a disorder of sleep or wakefulness. So sleep disorders are very, very common. And here's something called the Healthy Sleep Awareness Project, where the CDC was tracking sleep across the United States. And I like this map. It's called a heat map, and it tells you the percent of patients, and again, this is based on their subjective report, but that we're not getting enough sleep, meaning at least 7 hours of sleep. That's the amount that we think is optimal, at least 7 for adults. And you can see the darker red areas mean that they're more sleep deprived, I guess is what to look at. And I just find the map interesting because I would have never thought there was really a pattern by state. My state of Missouri, I guess, isn't doing the worst, but it's interesting, right, that there's a lot in the Southeast, for example, which I'm a little surprised, that are darker, and a lot of the rural areas actually seem to be getting more sleep. I think it is interesting to look at a place like this, Las Vegas, right, the city that never sleeps. That kind of makes sense that they would be sleep deprived, but it's kind of interesting looking at these patterns. I actually don't know what they clinically mean, but it's an interesting pattern. It does look actually similar to if you look at obesity patterns, by the way, the same sort of dark areas. And so there is a link between not getting as much sleep and obesity as well. And there may be a connection there. So what do I see in clinic? Well, the most common disorder that I see is obstructive sleep apnea, but we do see a variety of other sleep disorders: restless leg syndrome, sleepwalking, REM sleep behavior disorder, which is when someone dream enacts, seizures at nighttime. We see patients with narcolepsy. Insomnia is probably the second most common complaint besides obstructive sleep apnea. One thing that I'm assuming people would want to know about are what kind of sleep studies do we do, and what do they use for? And so usually, traditionally, if we bring someone in overnight, we put all sorts of sensors on them. You can see here's a gentleman here getting hooked up. Here's a child here. So we do sleep studies in children as well. This is kind of what a sleep room looks like at my center at Washington University. You have your own bed, your own bathroom. It looks kind of like a hotel room. But what we're measuring on these sleep studies is called a polysomnogram. We call it an in-lab because it's done overnight at our sleep center, PSG, short for polysomnogram. We look at eye movements. That's how we can tell what stage of sleep people are in, along with the brain waves, which are EEG. And then we look at muscle tone. That also helps us guide what stage of sleep people are in. A lot of times we're looking for sleep apnea. So we measure snoring. There's an audio sensor, as well as airflow. We're trying to see if they're breathing normally. And then we look at respiratory effort with 2 belts that go around the chest and abdomen. We obviously want to measure their oxygen levels because we worry about that in sleep apnea. We have a couple sensors that look at leg movements, an EKG monitor, and then there's video as well. That's infrared video, so we can see obviously while the lights are off and it's dark for any kind of unusual movement. So Very interesting. You can imagine they get hooked up to all these wires, which we definitely understand means that they're not going to sleep normally. So we're not really thinking that if I bring you into my sleep center, you're going to sleep exactly like you would at home. But what I am confident is when you fall asleep, even if it takes you maybe twice as long, if you're having problems with breathing or heart rhythm problems or seizures, that's likely happening at home as well. Here's a one clip of this is actually, I guess to be exact, 1 minute, I believe, of a sleep study. And you can see that we have these eye leads up here. Here's this chin muscle tone lead. Here's all these wavy lines looking at EEG, which are brain waves. You can see, I don't know if you've heard of something called sleep spindles. That's what your brain makes when you enter certain stages of sleep. That's a sleep spindle. Here's that EKG monitor, right and left leg monitor, and then a whole bunch of breathing channels here, including oxygen. And so this is kind of the data that we kind of flip through to decide what's going on. And usually we have video up as well. Fortunately, not everyone has to come in overnight for one of those studies. You could imagine there's lots of people that don't want to come in for a study. You can imagine that a variety of reasons. One, it can be expensive. Two, they don't want to leave their home because maybe they have responsibilities at home, kids, pets, family members. And honestly, they're afraid that they're not going to sleep very well. And so there are I'll call them newer, meaning over the last several years, monitors that we can get some of this information that we would get in our sleep lab at home. And it started off with sensors like this, where we put a lot less sensors, but we're still able to measure breathing. So this is mainly for home sleep apnea testing. There are now ones that just go over the wrist. And then here's a relatively new device called a night owl, which is literally a disc that you tape on your finger, and it can give you 10 nights of data. And again, with data transfer being basically through Bluetooth or through the cloud, basically they wear this and then throw it away the next morning, and you have all this data from that night or how many nights they wear it for. So we're kind of moving toward this. I would say this is brand new and we don't use them as much clinically, but I think going back to slide, the idea of having to bring everyone in for a full-blown sleep study for every sleep disorder is probably not going to be the case much longer. And that gets us to consumer sleep trackers, which is my term for Fitbits and Oura rings and Apple Watches that are measuring sleep at home, but not necessarily through a doctor's order or with me interpreting it. It's kind of a computer interpreting it. And they are definitely getting better with each version. I will say that when they first came out, they were not very accurate compared to our sleep studies. But every time I say that, every edition and update they have, they tend to get better, better, and better. They're obviously much cheaper than what you would do in our sleep center. So I don't expect them to necessarily get as equivalent, but we really still not sure what to do. They tend to be very helpful if you're trying to measure how much you're sleeping. And what I mean by that is, unfortunately, a lot of us will try to, burn the candle at both ends and not get enough sleep. And so it's a really good way to make sure that you're getting enough sleep by kind of looking back to see when you went to bed and when you woke up and give you kind of an estimate. What it's not as accurate at is telling all the different stages of sleep, especially if you have a sleep disorder like narcolepsy or sleep apnea. It really wasn't tested for that. I was looking at healthy sleepers when they made this. And so again, I think we're still learning a lot about them, and they definitely can be helpful, and they get people really interested in their sleep. So I do like them, but we just have to be careful about kind of making clinical diagnoses with them in isolation. So I think we have time because we're good. I was going to show two cases that the first is kind of a bread and butter case that I see all the time. And the second is something a little more unusual. And I thought that would kind of give you a flavor of what I see in my clinic. So this is a 35-year-old male complaining of snoring. His wife says that he stops breathing at night. He can barely stay awake at work at meetings and has fallen asleep at the wheel. He's overweight, but otherwise healthy. And so you can see that what we're concerned about in this gentleman would be sleep apnea, right? He's snoring. His wife says that he stops breathing and he's sleepy during the day. So someone like that could undergo one of these sleep studies. And this is, I showed you one clip before, but here's another sleep study. And if we kind of focus in on his breathing on the second half of the page here, you can see that the abdomen and thorax signals are showing that he's trying to breathe. This is actually a 2-minute slide, and you can see that there's just no airflow right here. So he just literally stops breathing. And then if we look at his oxygen levels, which I know may be small on your screen, it was at 97, 96. And you can see as he's not breathing, it's getting all the way down to 84 before we lose it on the next page. So what we'll see in people with sleep apnea is literally 1 to 2 minute breathing episodes here where they're trying to breathe, but the airway's closing off because of obstructive sleep apnea while they're so deep asleep. This guy was in REM sleep, that they have no recollection this is happening, and their normal response to not breathing, which would be coughing or gagging or waking up, the brain's so far asleep, it actually can take a really long time before it starts to wake up and correct the apnea. And so you can imagine this happening 20, 30, 40, 50 times each night is not only dangerous because of the oxygen levels, but also can definitely make you tired the next day. And so what we would do in someone like that, if we did a sleep study in the lab, is we would actually, here's kind of the oxygen levels going up and down, and all these little lines are all the different events, is that we would actually start a treatment that night to try to get rid of the breathing events. So if we saw enough of these events, we actually start something like a CPAP machine. And what I'm trying to show here is that with the machine, everything kind of normalizes. That is one of our most common treatments. People have probably heard of something called a CPAP machine, or positive airway pressure machine. And the way that works is instead of that airway closing off, it's going to basically deliver pressure to the upper airway to keep it open. And so instead of that airway relaxing when you get really, really deep asleep, this machine is going to keep the airway open by just simply giving pressure to the upper airway. As you can imagine, that if you know family or friends or have seen it on TV, some people do awesome with it. Some people do horrible with it. And obviously our job is to try to get it more comfortable if that's the treatment they want to use. The companies have done a good job of allowing patients to track things easier. This is kind of the more recent CPAP machines. They get all sorts of data about how much breathing events are still having each night. It'll actually measure that when you're on the machine. It'll give us data about how much people are using it and if it's leaking and so forth. So a lot of my clinic is taking this data, which actually is sent up to a cloud from their machine. So while they're using it, I can even via telemedicine, like I saw a patient today, with him being at home, I can get into his machine, get all this data, see how he's doing and help him troubleshoot. And so hopefully he can get on the machine and feel better. What we try to assume will happen if they use their treatment is that they'll feel much more alert and awake. They'll have improved learning and cognition, improved mood, and pretty much more. They're just getting good night's sleep. I put a picture here. Shaquille O'Neal is probably one of the few famous people that's actually come out and said that he had sleep apnea and responded nicely. So some people do great, some people don't. There are other treatment options that I'd be happy to talk about more as we have time in the discussion. Though I would still say the majority of our patients tend to start with CPAP as one of their options. So I'm going to end with one more case here. This is a 58-year-old gentleman who reports spells at night of acting out his dreams. He's punched a wall. He's fallen out of bed. He remembers having dreams that correlate with the movements and vocalizations that his wife reports. Here's a video that I stole from a textbook. I didn't think I could put a patient video because I know this is on the website, so I thought I could use something that's publicly available, but it'll give us the same flavor. This is a guy who's obviously sleeping in a sleep lab from, looks like a really old video years ago. And he's kind of batting away the, what it said in the caption of this video was that he thought there were these, what is it, pterodactyls? Are those dinosaur birds that were attacking him? So he's kind of he's trying to wave them away and trying to hit them away. That's what he was dreaming about. And so you could see how, luckily he didn't fall out of bed, but you could see how you could really injure someone next to you or yourself with one of these movements. And so what we measure when he's doing that set of activities, we can tell that this gentleman would be in rapid eye movement sleep. You can see these kind of eye movements that are darting around. What normally happens in REM sleep or rapid eye movement sleep, believe it or not, is there's a signal from the brain that's sent to your spinal cord to paralyze all your muscles. And so when you enter REM sleep, your arms, your legs, pretty much your whole muscles besides your diaphragm, because we obviously want you to be able to breathe. And then for some reason, your eye movements, all the muscles become completely paralyzed. And I guess the simplistic reason of why this would happen is so you don't act out your dreams. I would imagine there's probably more than that reason, but we haven't figured out why the brain would do this, but it's what happens in us and other animals. But in people with this REM sleep behavior disorder, or RBD, that signal isn't working. And so although the brain is telling the spinal cord to, hey, don't move around, they enter a dream, and you can see that his muscle tone is still there. I don't know if you can tell these kind of signals, and normally it should be kind of nice and silent. And so then what will happen is you'll start to act out your dreams because that signal is not getting sent. And what's even more interesting with this RBD is that when someone has this, and there's a lot of reasons someone can have it, but if it's truly not from a medicine or a recreational drug, for example, it can be the first and earliest signs of Parkinson's disease. So what I was going to show you in the next slide is that if you found someone with RBD, if you follow these patients, and again, they have no signs of Parkinson's disease at all, they may be someone very young in their 50s or 40s, but if you follow them over the next, in this case, 14 years, they all start to develop diseases like Parkinson's disease. And so what we've realized is that that signal not being sent is in just a tiny, tiny, tiny microscopic part of the brain, but it's just the earliest onset of Parkinson's disease. And we know that these patients over, as you can see, 12 years, about half of them will develop Parkinson's disease. And so that's obviously very interesting. It's also, it could be concerning if you're the patient who has that. But what that allows us to do is to take patients with REM sleep behavior disorder and try different treatments to try to prevent the onset of Parkinson's, right? So right now, I unfortunately can't say that we have anything that we know for sure works, but there are definitely lots of smart researchers looking at that. And so what I find really interesting about this sleep disorder is that it predicts the onset of a neurological disorder later in life. And so that was something that I found very interesting when I was choosing sleep as a field, is how it kind of interacts with different specialties. So that was my last slide, and actually going to even stop sharing so I can actually see everything. But I would be happy to answer any questions that you guys have.
So the first one is they would love to hear how often you deal with study patients on stimulants like Adderall, Vyvanse, and sleep issues.
Yeah, we definitely use stimulants or wake promoting agents because there are other medicines besides the ones you mentioned, mainly for patients with narcolepsy, although there are some other sleep disorders where they're so sleepy that they have to have these medications to kind of kickstart the brain. And as much as it sounds, as I know other people will use them in a non-medical fashion or maybe even in a legal fashion to help with wakefulness, they work differently in brains of patients who have these sleep disorders, meaning I think it takes them from kind of abnormal to normal instead of kind of normal to hyper, if that makes any sense. So, but yes, we definitely use those quite often.
What is your favorite part of being in the neurology field?
Yeah, my favorite part is I think a lot of these disorders are very complicated and obviously sometimes catastrophic for patients. And so I initially used to think of that as something I don't want to say feared, but I didn't look forward to, right? Who looks forward to telling a patient that they have maybe a terminal illness, right? But then I quickly realized that someone has to tell them. And I felt like it gave me some satisfaction that I'm trying to give my best effort and time to these patients. And it made me feel good that I was helping. Even if you're giving someone bad news, they need to know the news and they need to know how to handle it. Because I always say that it's very short-sighted to say something like, I keep on coming back to ALS or motor neuron disease, yes, that person's going to die, but they still need care until they die. And so my favorite part of neurology is that I think we have a good grasp that medicine isn't just getting people better. Sometimes you have to help them through the rough times.
Do you have a different favorite part of sleep medicine that you would like working on, or a certain kind of case that you like working on?
Yeah, my favorite stories in sleep medicine are not necessarily the rare stuff. Those are fun to teach, but my favorite are actually children with sleep disorders, because the things I remember most are kids that have poor sleep for whatever reason. Maybe they have sleep apnea, maybe they just are using their devices too much at night, and especially the really little kids. And what I mean by little is like in grade school, and they'll literally go from maybe the kid who's getting into trouble every day at school to the first in their class, and following them, where it's really a change in their trajectory of life from, maybe being the troublemaker at school to being the valedictorian. And so those cases are so exciting to me, because it's such a minor issue. Maybe in 1 or 2 visits, they'll go from that dramatic of a change, because sleep is just so important to kids and their brain development, that you feel like you're making literally a life-changing event with something that's something relatively minor. I'm not doing surgery or anything like that.
Thank you, Dr. Malhotra. So the next question is, what exactly are immunomodulators? What do they do, and in what cases would they typically be used?
Yeah, great question. And I threw all sorts of stuff out there probably that I didn't explain, so sorry. I will admit I don't always teach kind of pre-medical students, and you can tell I teach kind of more fellows, and so I throw things out there, not identifying it. So thanks for asking that question. The immunomodulator just simply means that you're giving them a medicine that basically usually suppresses their immune system because they have an autoimmune condition. And so in neurology, we'll use that for all sorts of different conditions. Multiple sclerosis is one of them. And so multiple sclerosis is where your body is actually attacking your nerve cells. And so we have to kind of suppress that immune system to help, which obviously comes with its dangers, but it also helps these patients live better lives. But we, believe it or not, use it for things even like migraines. We were learning more that even things like migraines can be a little autoimmune, definitely different neuropathies. I think those are probably the main ones that I could think of in neurology that we use it for.
The next question is, what is the final stage or point at which you decide a patient may need to be put on sleep medicine? Or how many suggestions do you provide?
Yeah, that's a good question. We see a lot of people on who have insomnia, especially nowadays. COVID has not helped that situation out at all, with all the worries and anxiety that everyone has, and stress. We try not to use medications. We do use medications, but we tend to think that behavioral techniques work best to get people to sleep at night. The form of therapy we use is something called cognitive behavioral therapy for insomnia, and it's that whole term. So we abbreviate it CBTI. Cognitive behavioral therapy for insomnia. And it's there are therapists that have this extra training that can do it. There are apps as well that can do it. If you just type in CBTI coach, I think is one of them, and there's some free ones. But we tend to start with kind of non-pharmacological options, but sometimes that's just not going to work, and they have to use sleep medicines. The only reason we tend to not want to use sleep medicines is it doesn't seem logical that a medicine is going to work forever. We want them to sleep every night for the rest of their life. And so we kind of worry about the long-term risks of putting someone on certain sleep aids. But sometimes that's better than not sleeping. So.
What is the most unique or interesting case that you worked on?
Yeah, that's a good question. Probably the most unique case I've seen, and I see mainly sleep patients, was there's a condition called Klein-Levin syndrome. The other name for it is sleeping beauty syndrome. But what happens is that young patients will literally go into spells of sleeping the whole day for days at a time, and not really acting like themselves. They'll just be kind of, but they'll look like they're awake, but they're basically half asleep, and they'll sleep the whole day, and then they'll just suddenly snap out of it. But it looks like they're basically most of the time they're labeled as being psychiatric, or they're faking it or malingering, or because it's just so bizarre. But it's a really rare condition, and so I was able to pick up one of those once in my career. It's called Klein-Levin, Kleine Levin, and they have some really good videos. There's a couple nice documentaries, or I shouldn't say documentaries, interviews with patients with that, including one I think that was that'll come up on Google if you look at them, Klein-Levin syndrome. think her first name is Alana, Alana. It's a really interesting story. She has some good videos, but that I had a patient similar to that.
The next question is, if you could give advice to your younger self about pursuing medicine, what would it be?
That's always a good question. I thought I had a pretty good idea because my brother was 5 years above me, so I kind of felt like I had some like idea of what I was getting myself into. So I think that helps. But I would say that you really need to prioritize. So you're going to be doing whatever job you're doing, whether it is medicine or law or business or whatever, a lot of hours of the day, right? So most likely, unless you are independently wealthy or win the lottery, you're going to be working probably more than anything else that you do. And so I remember people always saying, well, make sure you do something you enjoy. I do think that should be important. I don't think it's 100% of the decision of what you do. But so what I would say is that at least when I was deciding, I still think I made the right decision, but sometimes, you're worried about, how much money am I going to make? And what are people going to, and that's all important. Everyone wants to make money, but I will say with medicine specifically, that changes so quickly, right? If every time there's new administrations and bills about healthcare, that it's going to affect how much money you're going to make. So it's not I would say my advice would be, I would not go into medicine for money. Doesn't mean you can't live comfortably and that you want to make a living, but it's probably not, you should be going into it for kind of other reasons.
Thank you, Dr. Malhotra. So how often do you deal with kids that suffer from night terrors? And at what age do these start to taper off?
Yeah, that's a good question. I don't see kids as much anymore, but night terrors are very common amongst children. I'm going to guess it matters what age the child is, but 5, 10, 15, 20%. Actually, you could argue most kids will eventually have one or two. And that's where, just so people know what we're talking about, it's where someone will wake up from sleep and be screaming, and it's really dramatic and almost look like they're dying, but they will have no recall of what's going on. So they'll go right back to bed usually. The rest of the house may be awake. And then if you ask them about it in the morning, they have no clue what you're talking about. So it's not like they had a nightmare because they didn't remember a dream or anything, and you can't wake them up from it. It's kind of normal when you're younger, but you do outgrow them supposedly. But about 1% of adults will still have them. So that's still not that rare. So most of them don't come to see me because they've had it their whole life and they know there's nothing to worry about. Every now and then they'll come and see us because they're on the increase or something. For example, I think I saw one relatively recently because of stress due to the pandemic. The wife's like, what's going on with my husband? He wakes up in the middle of the night and screams, the whole house wakes up, and he was just having recurrence of his sleep terrors because of stress.
So how much overlap do you typically see between neurology and sleep medicine?
We definitely see it. It's not in every case because, as I mentioned, the majority of what I end up seeing is obstructive sleep apnea. You could argue that that's partly neurologic in the sense it's affecting the brain because you're not functioning, but we will see a lot of overlap with seizures in sleep, and we'll see a lot with dementia in sleep, like where they're having more memory problems. And then, as I mentioned, with that dream enactment with the Parkinsons, those would be the three that I think of most. But even a lot of times patients who've suffered strokes will also be sent to our sleep center to look for sleep apnea because that can trigger a stroke as well. So there's actually quite a bit of correlation. It's just not as direct as some of the things I mentioned.
Does anyone else have any last minute questions that we can quickly go over? I don't think so. It looks like you answered everything pretty well, Dr. Malhotra. Thank you for speaking with us today. We enjoyed seeing your presentation. And for our members, in order to receive credit for attending this session, there will be a quiz posted on our site that will be due at Sunday at 11:59 p.m. You'll need to get a 6 out of 10. I've posted all the links to our platforms and our website in the chat box. Please join us for our next session on September 1st at 7 p.m. with Dr. Lacey, a gastroenterologist from South Lake, Texas, and we hope you enjoyed today's session. Thank you.
Great. Thank you, everyone. Have a good night.
Thank you, Dr. Malhotra.